You're listening to the Pre-Hospital Care podcast on the Medics Academy network.
Welcome back to the podcast. Today we're looking at the science of communication in pre-hospital care with Dr. Stephen Hearns. So Stephen is a consultant in emergency and aeromedical retrieval medicine and the founding mind behind Scotland's Emergency Medical Retrieval Service, or EMRS, a government-funded critical care organisation delivering advanced pre-hospital care to major trauma and complex critical care patients across some of the most remote and unforgiving terrains in the UK. With over 3 decades of experience spanning HEMS, mountain rescue and expedition medicine, and indeed medico-legal practice, Stephen's become really one of the most globally respected voices on what happens to humans under pressure, and indeed looking at the science of communication under pressure. So today we're not just talking about clinical excellence, we're really talking about effective communication and how we steward communication well when the pressure is incremental and exponential. So specifically, we want to look at why it breaks down under pressure and what that costs us in pre-hospital care and what we can do practically about it in the moment. Welcome to the podcast, Stephen.
Listen, it's really good to be back. Thank you very much. Looking forward to this.
That's fantastic to have you with us, actually. And I guess just diving in, and I guess as an opening framer, could I get you to really speak to, pre-hospital care is one of the few environments where communication failures can directly be associated with outcome. In your experience, what does communication under pressure actually look and sound like when it starts to unravel?
Yeah, it's interesting. In your introduction, you mentioned the medico-legal environment. So I'm privileged to look at many cases from hospital care and indeed pre-hospital care where unfortunately things have gone wrong to the detriment of patients. And one of the biggest reasons that occurs is because of communication challenges, whether that's communication about trajectory of patients, diagnosis, or indeed just simple drug errors. And there are lots of reasons that our ability to transmit information and to receive information is compromised by pressure.
So time, Stephen, is often identified as one of the core communication killers. People don't prepare before speaking or speak too fast, or we spoke on a recent podcast around just collecting your thoughts, but stepping away from the noise and just having a moment to reframe and, just clarify the intention and the communication to someone on scene or indeed someone remote from scene. But just could I get you to speak to really how that plays out on a real incident and indeed what the fix is to get clarity of thought and clarity of communication?
Yeah, so there are multiple reasons that your ability to transmit and receive information in a high pressure situation is much reduced compared to having a conversation with a friend in a low pressure situation. And there are multiple things that cause that. There's the idea of time pressure, there's distractions, there's heuristics, there's task focusing and task fixation, and also the serial position effect. So simply time pressure. When we're under time pressure and we want to tell someone something, we often don't actually pause and think about what they really need to know. We just start speaking. We actually speak more quickly because we're trying to squeeze the information into a shorter period of time. And then the person that is trying to take on board that information, if we tell them something that's ambiguous in a low pressure situation, they would actually question us and they would clarify it. But in a time pressured situation, they just acquiesce, they take it at face value, and they could move on with an inaccurate interpretation of what you're actually trying to say to them. In addition, we are very often task focused, or we're still task fixated in pre-hospital situations. We might be looking at something that is giving us information. We might be trying to carry out a practical procedure when someone is trying to speak to us, either face-to-face over the radio. And when we are tasked, because we've got such a small cognitive capacity, a small working memory, then our situational awareness narrows when we're actually trying to undertake a practical task. And that gets particularly bad if we're struggling to do something, such as manage an airway or put in a difficult cannula. And when we're actually task fixated, studies have shown that we actually lose our ability to hear and we lose our peripheral vision. So people can be speaking to us on the radio or even right next to us speaking into our ear, and we're actually physically incapable of hearing them. In addition to this, our minds are working quickly. We are getting multiple stimuli coming in, and we're refocusing our attention constantly. And very often what I find is someone will start to pass a piece of information to me, and my brain is programmed to work quickly and take shortcuts. So they will start telling me something, and my brain will jump to a conclusion, an assumption of what they are trying to impart to me. And I will actually stop focusing on what they're trying to tell me, and my brain will move on to something else whilst they're still speaking. And there's every chance actually what they were trying to tell me in the latter part of their communication actually changed the meaning of it. Also, in the environments that we work in the pre-hospital situation, there are multiple stimuli and distractions coming in all the time, and indeed in the emergency department as well. So our ability to actually focus our attention on the people that is speaking to us is actually very difficult because there are so many other things trying to pull our attention away from them. And then finally, an interesting phenomenon is something called the serial position effect. And that is when someone is trying to impart multiple pieces of information to us in the one transmission of information. Say if they try to give you 6 pieces of information, what psychologists reckon is that we will focus and will remember the first couple and the last piece of information, but we will not actually focus our attention or recall the pieces of information in the middle. So often, even though information is transmitted to us and we look as if we're focusing our attention on the person that's speaking to us, we're not going to take on board all of the information that's given to us if it's coming in too large a chunk. So lots of reasons that when someone is speaking to us, our ability to take on board that information is compromised. Time pressure, the serial position effect, task focusing, task fixation, and the distractions, not to mention the environmental conditions that we sometimes work in as well.
So we spoke on the last podcast, Stephen, around closed loop communication and it being really an effective tool, but often in a way, the first thing that can be abandoned when the pressure rises. Could it get you to maybe unpack for us, why it collapses under stress and maybe how you can rebuild that habit of closed loop communication within a team?
Yeah, so there are maybe 10 different tools that we can use to try and improve our ability to transmit and definitely to receive information in a high pressure situation when we're working as part of a team. And one of those tools is closed loop communication, which is completely ubiquitous in the aviation industry. And it is really simple principle of I tell you a piece of information, you repeat it back to me, and I confirm that you've received that information correctly. And in our world, that could be it could be a drug dose, or it could be you asking me to complete a task and me confirming I understand you and that I'm content to undertake that task. What happens though if these things are not intuitive to us and we haven't practiced them, then as you say, in a high pressure situation, we can forget to try and use them, or we feel that there's too much time pressure and we don't actually utilize them. So many tools that we can use to try and control pressure in high pressure situations. The time to use them is not just in the heat of the moment when the pressure is on. We need to, our whole team need to understand these tools, and we need to use them routinely in low pressure situations and indeed in simulation, so that when we are trying to use these tools, when the pressure is on, that they're intuitive to us and everyone else in the team understands what you're doing.
Yeah, listen, I agree with that. And to your point about deeply embedding them within training so that they become the standard. And also you've kind of embedded it within your subconscious. So actually when the pressure is on you fall to the level of your training rather than the level of your expectation, you've already embedded these healthy practices and these habitual practices of closed loop communication. So let's just talk about something which you spoke about on the last podcast, which is absolutely relevant here, which is the concept of flash teams, and something that pre-hospital teams and critical care teams find themselves in every day, with working with unknown colleagues they've maybe never met before, and indeed maybe newly qualified staff or mentoring staff which are being mentored. Could I get you to maybe unpack for us really, there is maybe within a small high performing team, there's shared mental models. Certainly if I work with you, Stephen, and we've worked together for a while, I know just through the eye contact what you're thinking next and what you want next, because I've worked and there's that air of familiarization. But critical care and high performing teams are in new flash teams every day where there is this element of no one's a mind reader, that there might be a new team dynamic on every situation. Could you get to speak to really maybe how a team adapts to really almost to your point explicitly verbalize the mental model, the plan A, the plan B?
When I deploy with our EMRS team, I am working alongside a practitioner, and if we go by helicopter, there are two HEMS paramedics there as well. So that's a team of 4 people who have worked together for years, if not decades, who know each other's names, who know each other's skill sets and their strengths and their weaknesses. And as you indicate, we instinctively know through subtle cues what different people are thinking, how much pressure they're under, and what sort of zone they are in the pressure and performance curve. And that is incredibly powerful in terms of achieving a shared and an accurate mental model, in terms of working collaboratively to solve problems, and indeed to undertake practical tasks to do the best thing for the patient in the minimum amount of time. And built into that is vulnerability as well, where you have got a track record of working with other individuals, and you know that they are good, and you know that they know their stuff and they've got these practical skills. And therefore, if something is challenging them, then they feel quite empowered to speak up and say, I've tried to do that, I can't manage it, or I don't know how to do that. And that is what really forms a good collaborative and a high performance team. Things are very different though when we are in a flash team or a swarm team, when a group of emergency responders from different services comes together, or even just a group of clinicians from different parts of the ambulance service come together, because the fundamental basis of high performance teamwork is that shared and accurate mental model, that collaborative decision making, that effective delegation, and that cooperative teamwork to work together, in parallel to do the best thing for the patient. And that is very difficult when, in reality, the different people there have actually naturally got a different mental model as to what is going on, what needs to be done. There are going to be different people whose curve moves to the left, to the right, are going to be under different amounts of pressure in the same situation. You don't even know people's names, and you don't know what they can reliably undertake in terms of decision making, or indeed execution of tasks. And that is a very different team to a group of clinicians who know each other and trust each other, and work together to get the job done. And I think that it's really important that we in healthcare have got a term for that, and we've all got an understanding of the challenges of working in a team, a flash team or a swarm team. Indeed, we have some tools to try and overcome that.
No, I fundamentally agree with that. And I agree with the concept of slowing things down to speed up and being explicit rather than implicit, because to your point, there is these subconscious and conscious um, relationships built within a team where you're right. You can look at my face if you've been working with me for a number of years and just know where I am on that curve. Whereas the swarm or flash team, there is that element of unknown. So slowing things down, to your point, sharing the mental model, and also being explicit, utilization of names if possible, saying have I missed anything, and actually just almost not relying on those subconscious relationships, and actually just welcoming other people into that team element, and making them acceptable to speak up so that they can speak into your practice. And I think zeroing the command gradient like that gives people a powerful pivot to be able to speak into anything that you might have missed. Let's talk about leadership communication for a second. And to your earlier point about rally points, asking leaders to really hear from the team before they speak, which is challenging, for sure, but deliberately inverting the instinct to take control or command. And when you are genuinely under time pressure, Stephen, how do you make that inversion feel safe, rather than a loss of control for the team leader or indeed the clinical lead on the scene?
Yeah, so taking a wee step back from that, I think what I think is challenging is transition of leadership at a pre-hospital situation. And the classic thing in my experience is, an ambulance crew with a patient who are doing an excellent job, are in control of what's going on, are making decisions, carrying out the task to care for the patient. And then a critical care team arrives, and they are dressed differently, and they are really, there's a predisposition to a command gradient immediately being created when that happens. And often that is not at all the best thing for shared mental models and collaborative team working. And definitely, for me, first impressions count a lot. And I certainly, I'm still not good at this, but I've been really bad at it in the past. And I do remember, going back to when I worked with London's Air Ambulance over 20 years ago, the idea that the aircraft might land a couple hundred meters away from the job, and you would run with your rucksacks on. But when you got to that last corner, you started walking, so that you arrived at that scene, and your implicit communication was that I'm in control here, or I'm in control of my emotions. I am not feeling time pressure. I'm not out of breath, so that your implicit communication communicated to those people that you're in the right zone of performance. And also having respect for definitely the space within an ambulance. If that patient was in the back of the ambulance, no matter how time pressure do you feel, actually taking the time to knock the door of the back of the ambulance and waiting for the clinician to open the back, and actually sending a signal out, I've arrived, we are here to help you, can we come into your space and join you in the care that you've already initiated for that patient. Also, trying to have awareness and ownership of your implicit communication. And this is something that I'm really bad at. particularly which was revealed to me when we started wearing body cameras, but you might be going through the motions of saying to a pre-hospital clinician who's already there, getting a handover for them. You might be going through the motions of listening to them, but you might be looking at the patient, and the facial expression that you have got demonstrates something completely different and maybe quite negative about the judgment and the actions of the paramedic or the technician that have been there already and are looking after that patient. So it's being conscious with that. And then also just a simple thing of just asking someone's name, introducing yourself with the first name, and trying, if at all possible, to remember their names. So from the outset, consciously being aware of how you approach that situation, being respectful of the ambulance clinician's space and their observations and their mental model of what's going on, and trying to create that flat hierarchy right from the start, and avoiding a command gradient, and then slowly and gradually the controller, the leadership of the situation transitions, rather than just arriving in who was in charge before I arrived. Yeah.
Yeah, indeed. No, indeed. Just a few more questions actually, and one would be something that relates to something you said earlier, really about that concept of serial position effect. And so, could I get you to maybe unpack for us, the limitation or limiting, your request to 3 points, or indeed the communication to 3 points, pausing and having the courage to pause just to gather your thoughts and let the other person know that you're just about to give some information, but just also the ability to chunk information so it's well received.
So we talked earlier on about some of the tools that we can use to try and improve communication, and none of them are complicated. We talked there about closed loop communication, even just simple repetition, 20 milligrams of ketamine, simplest thing in the world. But what we also want to do is overcome that barrier of the serial position effect, and also not being transmitting information when someone is task focused or task fixated. So just simple things like actually pausing before we speak, before we transmit information, and actually thinking, what does this person really need to know? Chunking the information up into a maximum of 3 pieces of information per transmission of information to try and overcome that serial position effect. And then simplest thing in the world is focused attention. Is, listen, I've got something important to tell you. Can you let me know when you're ready to speak to me? Or are you okay for me to start speaking to you just now? And that would ideally include the person's name, using their name, maybe a hand on the shoulder, and actually making sure you've got eye contact with them. So chunking, pause and plan before you start speaking. Try maximum of 3 pieces of information per transmission to overcome that serial position effect. And then that idea of focused attention. I've got something important to tell you. Let me know when you're ready to hear it, or are you ready to listen to me just now? Really simple, but very highly effective.
And just finally, as we finish off, if you could change one thing about how we train as pre-hospital teams within the domain of communication, so not really clinical skills, but specifically their communication under pressure, what would it be? And indeed, and how and why would you advocate for that?
I think there'd be 2 things there. One is to talk to people and let them know about our limited cognitive capacity and to deal with high pressure situations, and why communication is difficult and is difficult for all of us, and give them maybe just half a dozen tools that they could use to try and overcome those pressures that they use routinely and use in simulation. Pause and plan, focused attention, repetition, closed loop communication, and sometimes structured communication as well. So let people know that these barriers to communication affect us all, and give them half a dozen practical, simple tools that they can use.
That's fantastic. So just as we finish off, we'll put in show notes Stephen's core cognition company, which Stephen runs, and the fantastic domains of education and indeed courses that Stephen does run. So please do head to the show notes if you'd like what you hear here, to really double click on and go deeper into these subjects. So that will be available to you in the show notes. It just leaves me to say thank you, Stephen. It's really powerful just to really spend time with you. And so thank you for that lived experience and the pearls of wisdom.
No, listen, I really appreciate the opportunity. I clearly love speaking about this sort of stuff. So any opportunity is appreciated, particularly on your podcast with yourself. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.